Hello everyone. Today we are here with renal diseases part 3. So today we will discuss multiple choice questions regarding acute kidney injury and chronic kidney disease. So here we see first MCQ that states a physician is reviewing laboratory finding in a 65-year-old male hospitalized with acute renal failure. So they have told that already the patient has acute renal failure. The patient is not any long term, he's not taking any long term medications, and renal function has previously been normal. Okay, the patient is not taking any medications long term, or the previous renal function was normal. What the lab says that now serum creatinine is 270 micromole per liter. Fractional excretion of sodium is 0.75. Urine specific gravity is 1.025 and urine sediment states the hyaline cast. So we see that urine sediments has hyaline cast and urine fractional excretion of sodium is 0.75. So it is less than 1. And the serum creatinine, it is raised. So what we see when we see in a patient that there is fractional excretion of sodium is less than 1%, so we should have in mind any pre-renal cause of the kidney injury. We know that there are pre-renal, renal and post-renal. In pre-renal cause, for example, if there is dehydration, hypovolemia, so there will be increased levels of aldosterone and they will preserve and reabsorb more sodium. And if there will any injury that injured the kidney, intrinsic renal injury, so when there is intrinsic renal injury, so kidney has less ability to reabsorb sodium because all the function will be disturbed. So in that case, the FENA, fractional excretion of sodium, will be more than 1 because kidney will fail to reabsorb the sodium and it will appear more in urine. But here the fractional excretion is less and urine sediment are stating the hyaline casts. So the most likely condition, what this is: hypervolemia, acute pyelonephritis, interstitial nephritis, obstruction due to benign prostatic hypertrophy or hypovolemia. So we have already discussed that when there is FENA less than 1%, so it is most probably pre-renal cause. So in acute pyelonephritis there will be no hyaline cast, but there will be increased WBCs rather, and in interstitial nephritis that it injures the kidney itself, so FENA will be greater than 1. And obstruction due to benign prostatic hypertrophy, in that there is also not the labs like this, so this is the hypovolemia, the pre-renal cause. Because acute renal failure, I have already told, has pre-renal, renal and post-renal causes. So when we approach the patient, we take history including all the non-prescription and all the prescription drugs and careful physical examination, and we give attention to the volume status. Besides, we see creatinine, blood urine nitrogen and electrolytes, urinalysis, including microscopic. We see fractional excretion of sodium. It is as essential to the initial evaluation. It is very useful in separating pre-renal causes from renal or post-renal in the patients who have not been on chronic diuretic therapy. If it is less than 1% in this, as in this patient, so it is a pre-renal cause. Of the possibilities listed here, the hypovolemia is the only condition that could result in this pre-renal acute renal failure. So furthermore, if BUN and creatinine ratio is greater than 20 and a urine specific gravity of 1.20 and hyaline cast, they all support the diagnosis of hypovolemia. Because if blood urea nitrogen and creatinine ratio is just like this, that in 1 to 10, so it will be renal causes. If it is 1 to 20, so it is pre-renal causes. So acute pyelonephritis, it will have WBCs or WBCs cast in the urine, and BPH, it will have something other lab findings, and interstitial nephritis, it is a renal cause, so it will have FeNA greater than 1%. So we move to the next question. It states a 62-year-old female presents with a 2-day history of nausea and diarrhea. She now experiences dizziness when standing and reports not able to hold down more than sips of fluid, but has been able to take her chronic medications. So she has not able to hold down more than sips of fluid, and now but she can take her chronic medications, that are glipizide, hydrochlorothiazide, lisinopril, atova, atenolol, and long-acting diltiazem. She has diabetes mellitus, essential hypertension, hypercholesterolemia, and chronic renal insufficiency, and her baseline creatinine is 133 micromole per liter. Lab studies: potassium 3.4, bicarb 19 mm per mole, blood urea nitrogen 28 millimole per liter, and serum creatinine 340 millimole per liter. Physical examination: she is awake but groggy, blood pressure is low, 88 by 50, pulse 58 beats per minute, flat neck veins, clear lung fields, regular heart sounds, no oral medication. A Foley catheter is placed and a small amount of clear urine with high specific gravity is obtained. So we see that the labs, the creatinine is high, small amount of clear urine with high specific gravity is obtained because Foley catheter is placed. So you as a physician must decide which of the following is the most appropriate initial treatment to correct this patient acute renal failure. So what we do, the option state: furosemide 80 mg IV in 1 dose, nitroglycerin IV titrated as necessary, normal saline, hemodialysis, percutaneous catheterization of the renal pelvis. This patient is in acute renal failure, probably by a pre-renal mechanism, because she just able to hold down more than some sips of fluid. So it is likely that she became dehydrated and was unable to maintain an adequate cardiac output because of the multiple antihypertensive medications she take. So the findings from the Foley catheter will rule out most causes of the post-renal obstruction. Then dialysis would be indicated only for chronic uremic symptoms, as in this. So dialysis will not the answer because chronic uremic symptoms are not there, severe hyperkalemia is not there, fluid overload or severe acidosis. In this patient, re-establishing the intravascular volume with the crystalloid fluid is imperative and is usually very effective for reversing the renal abnormalities. So there are no indications for other therapies listed. So the answer will be normal saline intravenously. So we move to next question. Which of the following is true regarding medication dosage adjustment for patient with chronic kidney disease? We know that the patients with chronic kidney disease, as we know, medication, some are excreted through kidney route and some through the liver route. So what is true regarding medication dosage adjustments? So here are the options. Loading doses should usually be adjusted. The loading dosage of the medication usually not need to be adjusted in CKD. Adjustment typically are not necessary until the glomerular filtration rate is less than 20 ml per minute per 1.73 meter square. Actually, medication adjustments are divided into 3 groups based on whether GFR is greater than 50 ml per minute per 1.73 meter square. Then if it is 10 to 50 ml per minute per 1.73 3 meters square, or if it is less than 10 ml per minute per 1.73 meters square. So this is again not the option. A normal serum creatinine value indicates that no adjustment is necessary. Sometimes the production and excretion of the creatinine decreases in older patients, so a normal creatinine level does not always correlate with the normal kidney function. So serum drug levels are usually required for making adjustments. This is the option because serum drug levels typically are not required for making the adjustments. So the answer is reduction of dose and increasing in dosing interval, or both may be necessary. So serum drug levels are usually not required, but the reduction of dose, as we know, as I've already told, that some drugs are excreted through kidney route. So there will be many medications require dosage adjustments in patients with chronic kidney disease. Medications are adjusted based on the GFR or creatinine clearance. So most medication adjustments require a reduction in the dose, lengthening of the dosing interval, or both. So serum drug levels are usually required. It is not the fact. Sometimes it may confuse. So this is the correct answer. A reduction of dose and increase in dosing interval, or both may be necessary. So 62-year-old female with a long history of chronic renal failure presents at your clinic because of fatigue. She gets tired after walking half kilometer but is comfortable at rest. Her only medication is verapamil for hypertension. There is no history suggestive of bleeding. Her physical examination reveals pallor but no other abnormalities. Labs: HB is 85 gram per liter, MCV 88 picoliter, ferritin 80 microgram per liter, vitamin B12 210, RBC folate normal, creatinine 379 micromole per liter, hemoglobin 90 gram per liter 2 months back. So they say most appropriate therapy: renal transplantation, vitamin B12 injection, dialysis, administration of erythropoietin, or oral iron. Actually, this patient, this have stated that she has a long history of chronic renal failure, and now she has fatigue. So we suspect that she is having anemia, and she gets tired after walking half kilometer but is comfortable at rest. So we see the patient has chronic renal failure and is presenting with fatigue, and her laboratory test reveal anemia. Because HB is 85 gram per liter, MCV 88 picoliter, but it is mostly normal. So it has, in chronic renal failure, the endocrine function of the kidney is impaired and erythropoietin production is decreased. This often results in normocytic normochromic anemia. So it is a normocytic normochromic because MCV is in a normal range. It is evident that this patient with HB of 80 gram per liter at MCV 88 picoliter has a normocytic anemia. In chronic renal failure, patients can also develop iron deficiency anemia with introduction of erythropoietin supplementation and dialysis. Why? Because erythropoietin, by stimulating erythropoiesis to greater than normal levels, often leads to functional iron deficiency and sometimes absolute iron deficiency. So administration of erythropoietin here may not work because it sometimes cause absolute iron deficiency, and dialysis patients are also in a state of continuous iron loss from gastrointestinal bleeding, blood drawing, or most important with hemodialysis, the dialysis treatment itself. So dialysis treatment itself cause iron deficiency anemia. Hemodialysis patients lose an average of 2 gram of iron per year. So thus iron deficiency will develop in virtually all dialysis patients receiving the treatment unless Supplemental iron therapy is given orally or intravenously. For this reason, in chronic renal failure patients who present with anemia, oral iron should be supplemented first before any administration of erythropoietin. So, oral iron should be administered before the administration of erythropoietin. And in dialysis patient, oral, if the question says dialysis patient is there, so oral iron will be ineffective and intravenous iron should be chosen instead. And what will be the goal to maintain the HB? It will be between 110 gram per liter and 120 gram per liter with hematocrit between 33 and 36%. So to achieve this goal, iron status should be monitored regularly twice per year in the patients with CKD stage 4 and every 3 months in the patient with CKD 5. So here, kidney replacement therapy is eventually needed by most chronic renal failure patients, and this can be done through renal transplantation or dialysis, but neither of these indicated at this point in this patient because she has come only with the complaint of fatigue due to normocytic anemia. So indications for renal replacement therapy are, we have already discussed that are metabolic acidosis, severe metabolic acidosis, hyperkalemia, pericarditis, encephalopathy, intractable volume overload, failure to thrive and malnutrition, peripheral neuropathy, intractable gastrointestinal symptoms, or if GFR of 5 to 9 ml per minute 1 per 1.73 meters square. So vitamin B12 injection here in this answer will be incorrect because its levels are in the patients are normal. In this patient, this level is normal. And administration of erythropoietin is done after iron supplementation has been initiated in the chronic renal failure patient. So in patients with CKD, we have to know that iron supplementation should be given before erythropoietin administration, and in the patient who need dialysis, IV iron therapy is far more efficacious than oral iron supplementation. Thank you very much.